consulting work, and being an accounts receivable manager. Specifically, she has 14 years of experience in mental health billing, both inpatient and outpatient, internal medicine, home health, pediatric day healthcare, medical equipment and supplies, and in the field of dentistry. So please welcome Anna.
Hi. So they can hear me. You're just not loud enough.
Thank you for being here. Her on the.
I think you guys can hear me, right?
Okay.
Yeah. Thank you for coming, and I hope I can answer questions for you guys. I know billing can be a black hole, but it's really not that bad. Especially you have someone that knows how to do it, or you're able to train. You have somebody that's able to train that person. It's really depends on having somebody there that really knows what they're doing, and when you have somebody to train them, that person's a really good mentor, then that's really what it's all about. So it's just trying to find that person.
Great.
So just to start, I know everyone probably has so many questions, and thank you for those of you who sent us questions ahead of time. So what our plan is, we're going to go through the questions that we have to have Anna answer them. If you need a clarification or kind of follow up based on that question, feel free to ask that. But otherwise, please hold any other questions to the end, because we really want to maximize the hour that we have and get through as much as possible. So, jot it down, whatever you have to do, but we will try to really stay focused. So we apologize if, you have questions and we're not able to answer them right away, but we just want to stay on track and get through as much as possible.
All right, so, and we're reading your questions as they came. So you may sort of sound.
I edited them.
Did you edit? Okay, Jen edited them a little bit. So when your client is a child, but parents want to meet with you to discuss the child or their treatment, and the child does not attend the session, is it recommended to bill 90846 under the child's insurance, since he or she is the client, or should we bill the parent's insurance as 90834 or 90837?
So the correct billing would be the 90846. And the reason for this is because a patient is not present, and it is a family therapy, and that is, and 90384 is specifically individual psychotherapy for 45 minutes. The two codes are 90846 and 9047. Those are referring to family therapy, psychotherapy. So the 90846 is without the patient present, and the 90847 is with the patient present. And the reason why you also want to bill for that is because it is referring to the diagnosis of the patient. That is why the family is being seen. They're not being seen for therapy for themselves. So that's why it has to have the demographics of the patient as well as the diagnosis of the patient, but with the code of 90846.
Can I ask a clarification?
Yeah.
If you have a child that's on one parent's insurance, but the other parent wants to come in and the parents are not allowing each other to use each other's insurance, how does that work?
Who is the child covered under?
Let's say the father, but the mother wants to come in for a parent session about the child. Can you still bill the father's insurance? I mean,
Yes,
he's saying
it would have to be billed because the coverage is under the father.
Okay.
Any other questions on that?
What are the CPT codes for telehealth services?
The CPT codes for telehealth services are the same codes as individual psychotherapy, which would be the 90832, 90834, 90837, as well as a crisis session. But there are certain circumstances that have to be qualified in order to use that crisis session, and that code is 90839. And the criteria to meet that code is that it has to be at least 30 minutes long, and the patient has to be in high distress and under it's life-threatening their situation, and the therapist has to place them, has to find a place for them to go. So for example, if there's a session going on and the therapist finds out that the patient is suicidal, at that time, the therapist then has to find hospitalization for the patient immediately, and that would qualify for a crisis session, but it does also have to be at least 30 minutes long, and that code is up to 60 minutes.
So clarification, so they have to go to a higher level of care to use that code? Like if somebody, yeah, I guess.
It's that they need immediate attention in some certain way. So something is going on, that they're in crisis, and some type of action has to take place.
So, but if we are able to de-escalate the situation and they don't go to a higher level of care, is that still billable as a crisis session? Like say somebody calls and says, I need to see you right now, I need to come in right now.
No, because what are you doing? If you're able to calm them down, then there's no reason to send them, then you're able to diffuse the situation.
So it doesn't count as crisis?
No.
According to insurance.
Yes, according to insurance. According to therapists, I know, and the client, you save them from going from that crisis,
Okay.
but according to insurance,
Got it.
no.
So that wouldn't include, a welfare check? If a family member calls and says, can you please contact the client and
To do
worry
it.
about them? And
Uh-huh.
then you would do an assessment, a suicide assessment, and give coping skills and all that, but you determine they're not in any
No.
risk?
No.
So can you bill it all for that under a different code?
It depends on in order to bill, the session even has to take place for more than 16 minutes. So it depends how long you are speaking to that individual for as well. So I would say that you most likely will be able to bill, at least if it's on the phone, but then you'd be able to bill for that telehealth session.
So it'd be the individual session?
Yes. And it does have a modifier. So for commercial insurance, and I'm not sure if you guys are familiar with commercial insurance is, that would be Aetna, Cigna, any of those kind of insurances. That requires a modifier of 95 to bill, and if it's Medicare or Medi-Cal, it's a modifier of G as in George, T as in Tom.
Are you gonna talk about modifiers later?
I'm going to talk about add-ons. If you have a question about modifiers, you can ask me, because I don't use that many modifiers when it comes to psychological billing, but I probably know the answer to your question.
Do you want to say that for the end?
Yeah, I'll save it for the end.
Cool. Any
There's-
other that's related to this question?
Related,
Yeah.
but it may show up later because I did email the question.
Then it's probably in here.
Okay.
Okay, so do you know the justification for insurance companies paying less for psychological evaluation intakes, 9071 or 791, than 60-minute sessions, 90837?
My experience, I'm not familiar with the 90791 being paid less. I have come across just one insurance company, even in-network, the provider is in-network, that they do pay less. But otherwise, I have seen that the 90791 is paid at a higher rate. Has anyone come across that that's not correct?
Cigna. Oh, are we not?
I'm speaking about Cigna.
Are we not supposed to? Okay, sorry.
Well, Cigna's the specific one I'm speaking about. That's the only insurance company that I know that they do pay less, and I don't know why the reason is. The only thing I could think of would possibly be because of the benefits of the beneficiary.
I've been told we can bill add-on codes for assessments during intake, such as the GAD or the PHQ-9. Is this correct? And if so, how do we go about doing that?
So the add-on code that can be billed with the 90791 is the 90785 add-on code. It's an interactive complexity add-on code. Now there is a criteria in order to bill for that code, and there are more codes, procedure codes, that can be billed with that add-on code, and those additional codes are the 90832, the 90834, 90837, and the 90853. And in order to bill with this add-on code, one of the four things have to happen. Either a report of abuse or neglect, an interpreter or translator is necessary, the use of play equipment with young children, or the involvement of parents with disagreeing views. So in other words, if the parents are not on board with whatever the treatment plan is and you're having issues with them, then you'd be able to use this add-on code. Now, I'm not sure if you guys I'm just gonna explain what an add-on code is. An add-on code is an additional code that you use in combination with the procedure code. So what that means is, for example, the 90791 code would be used in whatever data service that takes place. That would be on line 1 of the claim, the data service 90791. The second line item is going to be the same data service with the add-on code that you are using, and in this case it would be 90785, and that's how it would be submitted.
Any follow-ups on that? What are the CPT codes we don't know we can use? CPT codes other than 90791, 90832, 90834, 90837, 90846, and 90847.
So a few of the CPT codes that can be used that are not listed here, one would be 90849. That's your multifamily group therapy, and this one code, one insurance that does not cover this code is Medicare. And the focus of this group is the effect of the patient's condition on the family. Another code would be the 90887 code. And this code is when treatment of the patient requires explanations to the family or an employer or just anyone that's involved in the support of the treatment of the patient. In fact, Julia had called me probably a month ago and asked me for if I knew a code to bill because she spoke with an attorney regarding a patient. This would be the code she could have used. So it is helpful to know that because a lot of people don't know that they could even use a code to speak with an employer. Now, what you want to make sure is you have a release of authorization on file before you speak to anyone. So that is definitely what you want to do before you even have a conversation with anyone. And the other code that I did touch on, that I did speak about, was a crisis session, the 90839, which does require the criteria in order to bill for it. And then there are 3 psych testing codes that can be used, and it depends on how the testing is administered. The first one is 96102, which is administered by a psychologist. The next one is 96102. Oops, I said that wrong. 96101 is administered by a psychologist. 96102 is administered by a technician, and 96103 is administered through a computer.
And that is testing, like face-to-face testing, not any of the work that's done afterwards, right?
It's like the MMPI, and then you have to score it. So let me see if I have other ones. I have a list of what they are, so I could tell you, but it's.
But I mean, like when you score the work that you do after the patient's
That's
gone,
included.
that's included?
Yes.
Oh,
Yeah.
Okay. And do they get? Is there typically a limit though with insurances, like no more than 11 hours or something like that?
The code will specify how much they're going to reimburse.
Okay.
Did you have a question?
I just wanted, could you repeat the code for speaking to an attorney or employer?
Oh, sure. That one is, let me make sure I get you the right one. 90887.
Oh, okay.
I have a follow-up to that. Did it also include talking to the child's teacher?
Yes. It's anyone that's supporting the patient and their treatment that you would be able to use that code for.
I just have a point of advice. Just a point of advice about the 96101 through 103. It's not advisable to bill that willy-nilly. Oftentimes they require prior authorization for those codes. So now we'll sit down and do an assessment of somebody and think, oh great, I'm going to submit for payment for that code. But then you get a denial for lack of prior authorization. So get that prior auth before you do that.
Thank you. Yeah, the one with the testing numbers.
Do you have a question?
He actually
Oh,
said
okay.
them, so.
Okay.
What add-on CPT codes or modifiers might psychologists use?
Let me see.
We touched on the crisis code.
Yeah, we touched on the crisis code. There's also the 99354, and this code is used in combination with the 90837. And what this is for additional time. And what that means is, the 90837 code is for 60 minutes. If your session goes over 60 minutes, then you can use the add-on code in combination, and that would be the 9354. And this code is for an additional 30 minutes to 74 minutes. And if you're so that would be a total of 134 minutes. If your session goes over 134 minutes, there is an additional add-on code that you can use, and that is a 99355. And that is for 30 minutes in addition. So it's every additional 30 minutes. Now, what the CPT code book says is that there is no limit to this, but an insurance company can say you exceeded. So I'd be careful how long I would have that session for and just do a follow-up session.
Sorry, you said the 99354 was for the original 60 minutes?
No, the 908, it would be 900837 on claim line 1. And then if it's over 60 minutes, the next claim line would be 99354. And that's from additional 30 minutes up to 30 minutes up to 74 minutes for a total of 134 minutes. And then line 3, if you go over 134 minutes, then the next line would be the 99355, and that's for each additional 30 minutes. And the way that you bill that, let's say that you're billing 99355, and that's actually an additional hour. You would not list that twice. You would put 99355 one time, and the units would equal 2. If you put it down twice, it's going to be denied for duplicate.
And I actually bill that and get that every week. I get a 2-hour session. Insurance reimburses. So it's possible.
So I feel like I'm going to be red flagged and they're going to audit all my records, or I feel, am I being unreasonable? Which, go ahead and say yes.
Oh, no, it's not. I'm just saying because if you're billing with that code frequently, it's all about documentation. So for insurance purposes, you are required to put the start time and end time of your session on your notes. And so that's your documentation explain showing that that's how long the session did take place. And you might get audited, but when they see that that you have notes to document what you're doing, they'll leave you alone.
Okay.
I've been through many audits, so you'll be okay.
Okay.
Any other questions on that? Okay, so now we're going to Medicare and secondary plans. Can we expect Medi-Cal managed care programs to pay the 20% not covered by Medicare Part B? In what cases do they pay? Does this depend on the particular Medi-Cal managed care program?
So Medi-Cal as a secondary, so that's considered Medi-Medi because Medicare is primary and Medi-Cal is secondary. When Medi-Cal is secondary, it's all about the allowable, what their allowable is. So no matter what, actually, it's their allowable. So for example, Medicare allows $100 and they pay $80, so the patient has a $20 copay. That claim crosses over to Medicare, but Medi-Cal's allowable is $80. You're not going to get paid anything because it doesn't matter that they have that $20 that's owed. Medi-Cal's allowable is $80. They're not going to pay more than whatever the primary pays, because Medi-Cal is a payer of last resort. So if the allowable is higher from the primary, that's all you are going to receive. And that follows the same rule with Medi-Cal managed care. So Medi-Cal managed care is considered a carve-out of Medi-Cal. What that means is that somebody that has Medi-Cal chooses an HMO for their Medi-Cal. And even though it's through a managed care, it can be like Kaiser, it can be any insurance that's doing that's managing the Medi-Cal. They still follow Medi-Cal's rules. So it's the same thing if they follow, and it's Medi-Cal's allowables. So if Medi-Cal's allowable is lower than the primary, which it usually is, then they are not going to pay an additional amount. Now, if the deductible, let's say that the patient has a deductible with the primary and that crosses over to Medi-Cal, Medi-Cal will pay the deductible up to whatever their allowable is. And that is the same thing for some reason, if Medi-Cal's allowable is higher than the primary, then they will pay, if they have that 20% that's crossing over, they will pay up to whatever the Medi-Cal allowable is, but it's not frequent.
Can you give an example of that?
So an example would be, are we talking just about managed care? Because Medi-Cal, I could just do managed care because Medi-Cal is the same. So Medicare is going to pay $180 for a claim, and the allowable is $180, and no, excuse me, let me change that. Okay, so, the allowable is 180 and they pay 160. Okay, so then it's going to cross over to Medi-Cal to see if they'll pick up the difference. Medi-Cal's allowable is only $150. Because Medi-Cal's allowable is lower than the primary insurance, Medi-Cal is not going to reimburse anything. Usually it is a write-off when it comes to Medi-Cal secondary, just because overall the primary almost always is higher allowable, because Medi-Cal is a payer of last resort. Their allowables are pretty low, depending on what services. I can say I'm not familiar with the allowables for mental health. I have experience with different types of services. So, but I'm assuming it's still lower because it's not to make a profit when it comes to Medi-Cal.
Well, can I just add one little thing about that? So I used to do Medi-Cal evals for the county, and sometimes I wouldn't get paid because it has to be, the diagnosis has to be of medical necessity. So I do a whole psych eval and whole report and then not get paid on it, even though there was a prior authorization. So I always said to them, well, or you do a child who's going into foster care, so some of them don't have a diagnosis because they're fine, but every child in the county of San Diego requires a psych eval, and you wouldn't get paid on those if you don't put a diagnosis. So I said to them, I feel like it's insurance fraud if I'm putting a diagnosis on somebody who doesn't have a diagnosis, but
well, I'm surprised that Medi-Cal approved it without a diagnosis. That really doesn't make sense, because we'd get our TARS back, which is an authorization, if we didn't have a diagnosis on it when we would send it in.
It's just because the county of San Diego requires a psych eval for all children in foster care.
So
going to be adopted, who are in the adoption process.
So they're just trying to get it through to get approved, and obviously since authorization does not guarantee payment, always remember that.
Right.
So they'll authorize it, but it might not get paid.
What if I'm not participating in Medi-Cal?
Then I didn't cover that. You have to participate in Medi-Cal to get reimbursed. If you're not a participant, then there is no reimbursement at all.
Because, so I called Medi-Cal because I have someone who has the Medi-Medi. And there is an out-of-pocket of these 20% or whatever that is. And when I called Medi-Cal, she told me that because I'm not participating in Medi-Cal, I could charge the patient out of pocket for the co-pay.
Yes, that's correct, because you're not participating. So the patient would be responsible, but most likely since the patient's on Medi-Cal, has Medi-Cal, they probably can't afford it. So you have to consider that as well.
Right. But I can be participating with Medicare, but not with Medicare.
Yes, it's separate. The enrollment is totally separate from Medicare.
Okay, thank you.
You're welcome.
Could I ask a question? I don't know if this is the right point, so if not, just tell me. If someone has a Medicare number and they have a managed, is the right way to call it a managed care plan, or like a Medicare Advantage plan, where the HMO is administrating the Medicare?
So you're talking about a Medicare managed care program?
Yeah.
And,
but they have a Medicare number. Who actually gets billed?
It goes through the managed care, but you have to be participating. You have to be in network with that managed care as well.
Okay, so if somebody has Medicare and they're within a managed care plan, it doesn't get billed to Medicare. It gets billed to
the managed care.
United Health or whoever.
Yes.
Okay.
Yeah.
You probably want to not take that patient on unless you're sure you're in that managed care unless you're sure you're credentialed and contracted with that managed care program. So one way to look at it is when you do an eligibility check with Medicare, if they have Part C is a Medicare HMO or Medicare Advantage, same thing. It's three names for it: Medicare Managed Care, Medicare HMO, and Medicare Advantage. They're all the same way of calling the same thing, where somebody says, all right, I won't take Medicare anymore, I won't pay those premiums, I'll go to this plan that's being sold to me. You see commercials for them on TV.
Yeah.
And the people who enter those plans then have to go stay within that restrictive network. That's the thing they don't know. But they don't know that, so they'll come to you because you accept Medicare. And you say, great, you have Medicare. And they show you their Medicare ID card. And if you don't check their eligibility, for all you know, they have Medicare, but then they don't because they entered this thing. they took the deal with the devil and entered into
It's
this
an
net.
HMO.
It's
Managed
an
care is
HMO.
considered an HMO, so HMOs, if you're not enrolled, you don't get reimbursed.
And sometimes you can't get enrolled.
Are the rules the same in skilled nursing?
I'm not sure for skilled nursing.
That's like the real specific question.
Mhm.
I'm trying to figure out how
Well,
that
do you mean the rules to get reimbursed?
is just the billing.
Oh, the
just-
billing's the same.
The billing's
It
the
doesn't,
same,
it does,
and it goes through,
yes.
it goes through the same.
yes,
RFC.
yes,
Okay,
yeah,
alright.
because what it is a Medicare recipient, as he said, has decided to sign off to get into an HMO program, because the premiums are most likely less, but it does mess up the provider because, and also the patient, because the patient doesn't realize that to ask the provider if they are in network with that HMO. It's the same as any PPO or HMO. If you have PPO and if you're not in network, then they will pay at an out-of-network price. And for HMO, if you're not enrolled, there is no reimbursement.
Why do secondary insurances so often seem to ignore crossover claims that crossed over from Medicare? Is this legal? Is it legal for secondary insurers like private supplemental plans to deny payment and also stipulate that their members cannot be billed?
So for the secondary crossing over, it's a courtesy. So no, it is not illegal. If you see on your that it says that it crossed over, if you call Medicare and they say we crossed it over, and the insurance company may say no, it did not cross over. It's up to the biller to follow up with the secondary to find out the status, and if Medicare says they sent it over, the secondary saying they didn't receive it, and then the biller just needs to submit the claim along with the EOB from the primary insurance to get reimbursed. So no, it is not illegal. And as far as I know, Medicare is one of the main ones that does cross over. I'm not familiar with many other insurances crossing over. Some will, it's hit and miss, but it's always best to check because most secondary insurances will say they didn't receive it. The one that does get it is Medi-Cal as a secondary. So Medi-Cal is good about paying when they receive it. If Medi-Cal say they didn't get it, I believe they didn't get it. The other insurance companies just are buying time, and a lot of people may not have time to do follow-up. So if the follow-up isn't done, then it's out of timeliness once you come around to doing it. And that's the question asked, is it illegal? No. So that's why the secondary won't do anything unless the biller is following up on that claim. And then the last question is, so I would need clarification actually to answer this question, because it depends on what the denial is. And if the provider is in network, a lot of times the member is not responsible for the payment. But again, it does depend on the denial. So I could give you a couple of examples. Obviously, if the patient their coverage has terminated at the time of service, then the patient would be responsible. Now, if this is something that requires prior authorization, and all of these answers that I'm giving is based on in-network providers. So if the service requires prior authorization and prior authorization was not obtained, then no, the patient is not responsible for payment because it is the provider's responsibility to obtain that authorization. Another reason would be if
From a secondary? A prior auth from a secondary?
Oh, I forgot. It's
Okay.
secondary.
Yeah.
No, because it crosses over.
Right.
So scratch that. I was speaking about primary. Sorry, I forgot this was secondary. But for secondary, let's say that the primary, if the primary denies for no authorization, the secondary will deny for no authorization.
Sure.
So then that would apply in that instance. But yeah, you're right. I just said specifically, I was speaking specifically about primary. So the other thing would be if the primary sent back the claim for wanting review. If there's no follow-up done, the primary would deny it, secondary is going to deny it as well, and the patient is not responsible. But if the person's here that asked that question has
Your name.
So,
So, yeah, I did a neuropsych exam. It got paid, the 80% got paid by Medicare.
mhm.
And then the secondary ignored the claim, though it did cross over. So then I resubmitted the claim of coordination of benefits. And then the secondary came back and said, no, we're not paying that, non-covered service, and you can't bill the patient.
So, is there allowable higher than the primary?
That wasn't the issue, it said non-covered service. And my understanding is supplementals have to cover anything that Medicare covers.
They're supposed to, yes, so you could appeal it. Did you file an appeal?
I didn't.
Yeah, that would be the next step that you would do, is you would file an appeal, because insurances will deny things that are not correct. And if they're not going to fix it over the phone, then you would have to file an appeal and submit. You did submit the OB, but still I would do it in writing, because I did work for Aetna, so I know the side of processing claims as well. And it would be, when you do an appeal, it's red. So some things, sometimes it's not red, meaning like if, for example, Medi-Cal, you have to submit a claims inquiry form. And what that is it gets scanned. So when you have to actually write something out, we pay attention more, because we have to take the time to read it.
Okay. Well, as soon as I clone myself, I'll get right on that. Thank you.
But yes, you're right. They since Medicare paid for it, then they should cover it as well.
Okay. I just got screwed, in other words.
Yes. Yeah, you did. Sorry.
That didn't feel that good.
Well, they count on people not following up. That's the whole
they
thing.
do. They
It's
do.
just like, okay, it's denied. All right.
Makes you very cynical working in this field. Yeah.
Are there any other ways to help patients obtain reimbursement for out-of-network services aside from providing a super bill?
Unfortunately, no. The super bill is what they use to get reimbursed, and that's the only thing that they can use to get reimbursed. I mean, set aside a 125 cafeteria plan, but that's their own money that they're putting into that. No, there is no other way for them to get reimbursed, unfortunately.
I don't know if this, if you provide a super bill and then they ask you to call the insurance for them, can you appeal as the provider, even if you're not paneled with that insurance?
So
or would they have to do it?
I would have them do it. If you're giving them the super bill to take care of, to get reimbursed, that responsibility is put on them. And they're to be told in the beginning as well that they need to call to check eligibility, to check, I would say, benefits. So that way they know if it's going to be covered. And I mean, I don't know what the denial was for. If anything, I would just, when that happened with me, what I would do is, since I'm a biller, I would tell them how to go about filing the appeal or what they should do, what steps they should do. But no, it wasn't taken care of in-house if we provide them a super bill.
I was just going to add that I see a lot of clients for consultation and fertility, and a lot of times the insurance doesn't cover it. So what I do is I just give them a receipt for services, and then they can use that if they have like one of the flex spending plans. They can reimburse it that way.
That's
so
the 125 cafeteria plan.
Okay.
Yes, yeah, flex spending.
Gotcha.
You can also submit for them to get reimbursed.
Oh, right, we did, we would actually do electronic billing for them, but they would do the follow-up. We just send off the bill, they would have to do the follow-up. So yes, you can submit for them, yeah.
I'm sure for yourself, obviously, but
yeah, you can.
want to be extra hopeful that
exactly, yeah. Yes, I've done it both ways. And first we used to give them a super bill, but then once we got set up electronically, we would just send it out for them.
And I've created email drafts for specific, like, here's what you do, you ask for this information, you call this number, you know, and I save them in my email so that anytime someone has a question, I just send them off. So that I have all the information for those clients.
For appeals or for submitting?
For both.
Oh, look at you.
She's my friend.
Okay. What is a good process for converting from an insurance business to out-of-network and cash practice? The steps, timeliness.
So what I would do is make sure you contact the insurance company. You have to contact the credentialing department to find out what it is that you need to do in order to disenroll because you're going to become an out-of-network provider. Usually you have to send in a letter on your letterhead explaining that you will be disenrolling. I would suggest that you do it 60 days prior to going out of network, because you want to give your patient, you have to notify your patients as well. And if they want to decide to move to an in-network provider, you don't want to stop that continuity of care with them. But with Medi-Cal, you do have to fill out their form to disenroll, so it's not a letterhead. You can download that from online. And Medicare is the same, that you have to disenroll. They have their own disenrollment that you would have to complete. And what I would also do is make sure that you speak to the patients that are going to stay with you and explain to them, I'm assuming that you'll be providing them with a super bill. Let them know that what that process is, that you will be giving them a super bill and they will be able to submit that to their insurance company. I would suggest collecting payment at the time of service. It's always much more difficult to collect at a later time. And you are going to want to stay on top of that payment, not to let it get behind. And we'll go into that a little bit later about what you do for like collections. But basically that would be it. It's somebody here that has a specific question about like disenrolling, and because you're going to have your same accounting system, whether you use software or whether you use billing software or QuickBooks, whatever it is, it's just a matter of disenrolling the insurance and making sure that the clients know what's going on.
In your experience, what are the typical out-of-network reimbursement rates that people can expect?
Out of network, it's anywhere from, for individual psychotherapy, I've seen it as low as $60 to probably the highest, I would say maybe $109 for out of network. And that's your 90837 code. Now it does depend on insurances, and from what I've experienced, UBH is the highest one that allows the highest allowable, and then I would say Cigna and Aetna. And Cigna and Aetna are pretty much the same. So, but I would say UBH is the one that allows the highest allowable. But also UBH likes to send back claims for medical necessity.
Can unlicensed therapists such as psych assistants bill insurance companies?
Yes, they can. So a psych assistant can bill an insurance company under the supervisor, clinical psychologist that's supervising them. And the claim would have to indicate that as well. So it would have the psych assistant's information on there, as well as a supervising psychologist information on there for reimbursement.
Is that in network or out of network that you're talking about?
It would be for out of network.
I'm sorry, can you clarify that a bit? That was actually, that's the gold nugget for me here.
So yeah, a psych assistant can be reimbursed for out of network as long as a supervising psychologist is on the claim as well.
Okay.
So a super bill, essentially.
Yeah.
A super bill, what about in-network?
To bill in network?
Yeah, for the psych assistant rendering the services.
That I'm not sure of. I would have to check. You could.
It's Medicare. We're going to talk about that, remember?
But most is
Oh, you're
no.
talking about Medicare.
Right.
Well, that's one of them.
Oh, okay.
So for the
Okay.
most part, that's going to be a no. There are like exceptions, like Medicare or like
Yeah.
certain
UBH.
facilities or,
Medicare,
like,
yes.
UVH is one of them. Okay.
Those are the only two I've ever heard of.
Well, I talked to Medi-Cal yesterday.
Medi-Cal will also.
So Medi-Cal said that they absolutely will, they'll reimburse for psych assistants rendering the services.
But
As long as
the supervisor is
in the.
That's what I was going to say.
Yeah.
Okay.
The exception to that is community health group.
Okay,
They won't allow it, but every other Medi-Cal managed care program does allow it.
okay, so even if they're managed by an HMO, it's not just straight Medi-Cal, it's.
Almost nobody's in straight Medi-Cal anymore. I
Right.
almost don't see that at all. So it's
Right, that's
always-
why, that would be disheartening.
Yeah,
Okay.
Yeah, so all the Medi-Cal managed care programs allow it except for community health group.
Okay, and I don't wanna sidetrack too much, but for the other question, for the in-network stuff, which seems cockamamie to me that they would do it out of network with a super bill, but not in-network. Is there any way to find out that information, which do and which don't without taking any time here?
Yeah, you would have to contact the insurance companies to ask them, but as Julia and
I mean, I
Jennifer
called
said, I
when
know
I was
UVH
unlicensed, and it was only UVH and then
Yeah.
managed care.
Okay. Thanks.
And Medicare as well, but Medicare stipulates that the licensed supervisor has to see the patient first, establish a plan of care.
Okay.
So actually,
That's your
We're gonna talk
incident
about
to-
that.
Incident to
Yeah.
billing, yeah.
Yeah, so actually, Anna, do you want to explain the incident to billing for Medicare?
Sure. So the incident to billing applies to psych assistants and ASWs. So what that is that as long as the supervising clinical psychologist is enrolled with Medicare, then the psych assistant will be covered as well as an ASW. However, what has to be done is that the clinical psychologist is required to meet with the patient for an evaluation and to establish medical necessity. And the provider is in direct supervision, and the claim must have the billing provider's information on there as well as the provider that's rendering the services. So if someone needs to know how to specifically fill out the claim, I can give you that information what goes where on the claim.
Did I answer your question?
Mostly, yeah.
Is there something else you still need to ask?
Well, I was working under a different supervisor than I'm working under now, and they were managing to get reimbursed, not Medicare. It was TRICARE, and yeah, so I had a feeling of
So
something-
often, a lot of psychologists think it's okay to do this,
Right.
and will just not put the rendering provider's information on the claim, put only their information, but they're not the ones seeing the client. And so
Insurance
that-
fraud.
It's insurance fraud,
Right.
so don't do that.
Right, and I had,
People do it. People do a
Yeah.
lot of things they're not supposed to do.
right, okay. So, I mean, my.
And as an unlicensed person, you do not want to be involved in
No,
it.
I don't want to be involved in that. It's one of the reasons I'm no longer there, so, but yeah, okay, thanks.
Alright, so we did that. Okay. So, how and when to use collections?
So prior to even going to collections, what I would say, I'm going to speak first about doing in-house collections before you want to send it over to a collection agency. So first of all, your aging. Your aging is something that the biller has, that's like their Bible. That's what they go by. And what I would suggest is when the claim is at we're talking about private pay because collections. So if the patient is at 30 days, they get a statement mailed to them. But if they're at 30 days, that's when I start calling them. Now the collection rules are for the law is that you're only allowed to call somebody once every 2 days, and you can only leave one message or speak to them directly one time. So what I would do is if I'm calling them and if they're not answering the phone, I wouldn't even leave a message because they might just ignore and you don't want to leave a message either because you don't know who's going to hear that message because that's considered harassment. So, and the other law is that depending on obviously what the amount is that they owe you, you really want to consider if you're going to sue them. But if you're if you're doing residential treatment, obviously that's very expensive, and I did do residential billing. So you do take that into consideration, and in order to sue somebody, the limit is 4 years. So you have up to 4 years from the time you receive payment. So even if, let's say it's 5 years later and the patient makes a payment, that 4 years starts again. So it's from the time they make their last payment that 4 years applies. So when it comes, and then what I would also do is try to set up a payment plan with that patient. And when I would set up a payment plan with them, we come to an agreement of how much they can pay for the outstanding balance, but the understanding is if they're still a current client with me, then I would or with the provider, sorry, I would have them know that they have to pay that full amount because you don't want that amount to then go into a balance. So they'll make payments on their old stuff, make a certain amount payment, but stay current with their current bill, what they have. Now, if their balance gets to 90 days, and I'm speaking about somebody that's not following a payment plan, that they're just not paying, that's when I would consider collections. Now, prior to sending them to collections, I would make one last effort sending them a statement. And when you send them a statement, or even when you speak to them on the phone, you cannot tell them that they are going to be sent to collections. That's against the law. You can say to them, further action I may have to take further action, but you cannot say to them specifically, I may have to send you to collections, or I am going to send you to collections. That's against the law. You're not allowed to do that.
What's the reason for that?
I don't know. I don't know, but that's.
I would want someone to warn me.
Well, and that's.
It's in the consent, essentially,
right.
when you're
Well,
signing
when
it,
you
it should be in
say,
the consent.
that's why you say we may have to take
We have
further
to have
action.
We have to have it in our consent if we take our clients to collections. So you legally cannot take them to collections unless they didn't sign it in your consent. So that would be the other argument, is that they were warned at one point.
Well, and when I send them their final attempt to collect, what I put on the letter is I say further action we may have to take further action within 15 days. So that's their warning that something's gonna happen. I mean, I would think that they realize it's probably gonna go to collections. That would have to be the next step. So and I do that when it gets to 90 days, and if then we don't receive payment, then I would send it over to collections. It also depends on what the balance is. Is it really worth it? Because the collection agency obviously is going to take a cut of that money, so you want to consider that as well.
In the consent form, can you say if your balance is unpaid within 90 days, then you'll be sent to collections?
Yes, on the consent form, you can do that.
But therapeutically, think about what that means.
Yeah, exactly.
Do you want pissed off patients? I don't.
So what do you put in your consent?
I don't take people to collections.
Oh.
It's my personal preference.
You don't take what?
People to collections.
Oh.
I'd rather not have people filing grievances and things like that against me. Yeah. I'll just eat the money.
Question, if people do take to collections, is it common practice for psychologists to add interest to their statement or no?
I don't know if it's common practice. We had it in our form that we would, but we never did. That was my decision. I don't know. I just didn't feel right about doing that.
Yeah, if someone's already having trouble paying and then you're adding interest, that just seems like salt in the wound, right?
I don't know people do it.
Some companies do, yes. Yeah.
Alright, so we're gonna go ahead and open it up because we only have like 5 more minutes. So if anyone has any burning questions, they want to make sure they get answered, now is the time.
I had a follow-up. It didn't end up getting, I don't know, maybe it got retyped, but it was about the telehealth CPT codes. I was wondering, say you're doing exclusively telehealth treatment, so it's not in between in-person visits or something like that. Can you just flat out bill the 908, 32, 4, and 7 codes if you're just talking to them over the phone, like on a weekly basis?
Yeah.
You can? Oh, okay. I thought you could.
Just make sure you use
Okay.
modifier. The modifier, if it's of 95, if it's commercial insurance, and if it's Medi-Cal or Medicare, it would be G7.
Okay. Thank you.
So I am interested to actually do billing, so I have a very basic question. I haven't done billing, and I was wondering if you have any suggestions about resources, just kind of step by step and doing billing online, through because I have no idea.
So you're talking about like doing electronic billing?
Yeah, I have a biller, so I want to get rid of my biller and do this work myself.
Oh, you want to do it
save money.
yourself?
Yeah.
And do you have a software?
I don't have software, so I was curious, like.
What is being used right now to do the billing?
I don't know what they're using.
Oh, is it outsourced?
Yeah.
Oh,
yeah, I've
okay.
been paying them. Yeah, for
Okay.
years.
Okay. So you don't have a billing software yourself.
I don't know about it.
Are you wanting to get a billing software? Or
That's
you're
what
not
my
sure?
question is. Like, I don't know.
Do you
how
have
to
an
navigate.
EHR that you use for like notes and scheduling?
Do I what?
And like
Electronic
health record?
So is it paper?
That's the way to do it.
Yeah.
So you do it paper?
Paper for
Your
Yeah.
notes?
Yeah.
Okay. Well, if you're not sure if you're going to get software. I'm just
EHR is
asking,
the
what
best
about
way
your
to go.
post-its?
What is it?
The EHR is the best way to go. Electronic health records.
Okay.
I pay like $60 a month, and I have everything all electronic,
Really?
paperless.
Through
You can bill.
And yours
keep
is,
track of
does,
everything.
that's what I was gonna ask, does yours do billing and posting
Electronic
and
health
scheduling?
records?
Does everything?
Yeah,
have to pick a service.
Which one do you use? So,
I use Therapy Notes.
I use Simple Practice.
So I have demoed therapy notes because Julia had told me about it. So I was looking for a client one time, and actually, I don't think I've
I don't
tried
do insurance
simple.
billing.
No, I know. I don't think
So
I've
I-
done. What did you say?
Simple Practice. I do insurance billing, and I set it up to where it's just everything is very automatic. It just posts automatically. I still go in and double check that my claims are being paid correctly, but I get the electronic UBs. They post in Simple Practice and do the write-offs and send the invoices to the patients. It's very streamlined that way.
and just, I just got on some insurance panel, so you contact them, there's an online thing to.
Yeah, some of them it's like very easy to just like the enrollment because Simple Practice uses a clearinghouse. You have to use a clearinghouse for your electronic claims. Simple Practice already has one that they use, so it just automatically goes through them. So certain ones like Medicare, I had to get enrolled. Cigna, it was ready to go. I just started submitting it.
Is there any resources to help me? It's a lot of information, it's totally new for me, so to kind of navigate this.
There's a lot of like stuff online, like different.
You can
I want to know
also
kind of where to start.
you can also contact the EHRs, and they do free demos. So like when I was first starting, I just did a free demo with every single one that was out there, and you can ask them 8 million questions, and they'll answer it for you because they want you to buy their product.
Yeah, another one, so Office Ally, if you don't want like a full EHR, Office Ally, you can submit electronic claims. You have to enroll with Office Ally, but they're another clearinghouse that most
Office Ally, and Office Ally is free.
Yeah.
Ally?
ALLY.
Okay.
And it's very easy to use.
This is a little overwhelming to me.
Yeah, it's very easy to use, and you can check the status of the claim to make sure it went through. We'll send it back to you the following day when it goes through its edits if there is an issue with it. To me, that's the simplest one. That's why I was asking if you have software, but you have an outside billing company, so they do all your payment posting and everything.
I can see mine doing this myself.
So what was the only downside about that compared to the other two? It doesn't.
Office Ally, well, it depends. If you want a whole software, billing software, then Office Ally would not be the way you want to go because Office Ally only does electronic billing. That's all the platform that it's set up for. And what Julia and Jennifer have does not only does it do the billing, you can post in there, and it just has everything. But you can do scheduling.
Yeah, so
your
for
notes.
Simple Practice, for example, like I put an appointment on the calendar, I put in the CPT code is attached to that appointment. The client comes in, they pay copay, whatever, I put that in there. Then it like automatically when I go to my insurance section, I can just create a claim just from that information, and diagnosis and all that, it's all in there in the notes. And it just creates the claim, it sends it out. Versus like for Office Ally, because I have used that, I have to go in and enter all that information again for the patient.
Well, you can store it.
And you can store it.
Yeah.
But for like different, if I'm using different CPT codes, you have to put that in.
Right.
But you can store like.
It's a freehand. It's data entry with Office Ally.
They're all HIPAA compliant.
Yes.
Oh yeah.
Yes.
What software do you use?
Well, I use different ones. I have Valent. I also use Office Ally. We go straight through Medicare, and we use a clearinghouse through Medi-Cal. So I use multiple ones.
I have a dumb question. What's a clearinghouse?
Oh, clearinghouse is a third party, so what that means is instead of, you can bill straight to, for example, Cigna has their own portal that you could just bill directly to them, and then you wouldn't have a clearinghouse. The clearinghouse is the middle company that grabs that claim and sends it off to the insurance company, like Cigna, if that's what had to be done.
And that makes it easier, better, more like.
Costs the provider more money if you have to go through a clearinghouse.
Okay, it costs more money.
Yes, because then you have to pay that clearinghouse.
Right, it's a middle person.
Yes.
And then what's better about it than not doing it?
Well, it's just that a lot of softwares don't have it set up that it can go directly to the insurance company. And that's also because some insurance companies just don't have it set up that way. They require that you go through a clearinghouse. And I don't know why it's easy, probably because they don't want to be responsible for any IT stuff, I'm guessing. I don't know.
Perspective on that. A clearinghouse is kind of like a post office, so they have a bunch of addresses. And so you just send it at the clearinghouse and the clearinghouse routes it to wherever it should go. Rather than logging on to a website, submitting a claim through a specific website, when you're dealing with several different insurance companies, you're logging into several different websites. It's really unwieldy and awful. And if you're using an electronic health record system or an electronic billing system, you just tell it which payer ID or which insurance company you want to go to, and it'll route your claim to where it belongs. It's really great to use. I think Office Ally is a nice choice if you're not going to use the scheduling and the documentation part of the software. If you just want to do electronic billing, Office Ally is free. It's really nice.
Yeah, it is. It's easy. It's easy to use.
Back there.
Earlier you mentioned some textbooks. I don't know, those textbooks or texts about coding, like CPT code books.
Oh, I said in the CPT book, yeah.
Okay, is there any of those that you recommend that's like a good reference?
I would just go to Amazon and order the most current CPT book.
Okay, thank you.
You're welcome.
Is there a way to find out what the maximum allowables are if you're out of network before you bill?
No.
Before you, like,
No, what they tell you, what they will tell you when you ask them what's the allowable is they will say that it will be determined at the time of adjudication of the claim. And one of the things that it depends on is your geographic region, because they want to see if there's other providers in network that the client could have gone to that's in a reasonable area that they can get to. So there's different factors that come into play.
So when somebody comes to me and wants to use me as an out-of-network provider, I basically can't tell them what their portion of the payment's going to be.
No, the only way you would know is if you have another patient that has the same benefits and the same insurance, and you can give them an idea. And even then, I would say that
you don't know if it's going to change.
That this is based on what you've received in the past. It's about this much.
And what Aaron has taught me is that you can have the client call and ask themselves. So at least they hear an amount and they, do that on their own. And then if it gets different when it's, finally reimbursed, at least they made the effort to call and find out on their own.
Oh, I wanted to mention something about billing insurance. When you bill insurance, what you also want to do is bill at a higher rate. You don't want to put it, now I'm talking about if you're it could be out of network, but really it's in network. If you're in network, even though you know what the allowable is, you do want to bill at a higher rate. And the reason why is because if the insurance company later increases the rate, then they will retroactively go back and pay you what that adjustment would be from the time that rate increase took place, as opposed to if you're billing at the allowable rate, you have to send corrected claims for all those claims, and really who has the time to do that?
How often do they actually raise their rates though?
They look over, well, how often?
It happens?
Not often.
That's not a myth?
Well, Medi-Cal, their fiscal year closes in June, the end of June. So July, so that's when they determine if they're going to do an increase. It doesn't happen frequently with insurance companies, but the way that you set up your software anyway is that it will automatically do that write-off. So it's not you having to do it manually.
With the
Wait, sorry. We're running out of time, and we had one last question. It was in the back.
Go ahead. Mine's just about the book, like if it really makes a difference what year.
There was actually one did she leave? Okay.
It would only make a difference if things have changed. So
probably 2018, 2019, not a difference.
The CPT book?
Yeah. They should be fine. Yeah.
Okay. So we can get an old one?
Unless something's changed. I mean, things change. I don't know how old you're talking about.
Just off and old.
I do have my hand up. You just didn't see it before.
Go ahead.
Yeah, he is tall. Retroactive claims. How likely are they? How do you apply? And how likely are they to be?
So, are you referring to something that's already been billed or something that's been denied?
Neither.
So, if it's something that has never been billed, you usually have up to a year to bill it. Are you But are you a Medi-Cal provider?
Yeah, there'll be the
So
supervisor will be-
no, Medi-Cal. Do you also accept Medi-Cal?
Yeah.
Are you a Medicare provider? Medi-Cal, sorry.
Medi-Cal, yes.
Yes, you are. So Medi-Cal has other timeliness. You do have up to a year to bill, but it would only be at a rate of 50%. So the first 6 months, you'll get reimbursed 100%. 7 to 9 months would be 75%. And 9 to 12 months, it would be 50%. Now with Medi-Cal, people are afraid of Medi-Cal, but with Medi-Cal, it's all about timeliness. If you know the rules and your biller, what the thing with Medi-Cal is, your biller has to know the rules and needs to understand the terminology of Medi-Cal, and you can have a claim going on for years and get paid 100%. They just need to know how to work it.
Thank you guys. Anna has cards up front. If you have questions for her or you want to use her, feel free to do so. Thank you.
Thank you, everyone.